and welcome. Today we're going to be discussing nasogastric tube insertion. My name is Glenda Trevino, and we'll be discussing this for the Copper Queen Community Hospital. Our objectives are easy. Today we're going to discuss the human anatomy. We're going to identify contraindications for NG tube placement, identify reasons for insertion, review insertion technique for placement. This is the cross-section of the human head. As you can see the nares, the nasal cavity, you can see the cranial bones, you see the tongue, the esophagus, the larynx, and the trachea. As you notice it with the brain, there is a thin layer between the nasal cavity and the brain that is the cranial bones. This is where a basial skull fracture can happen. Basial skull fractures or suspected basial skull fractures is a contraindication for NG tube placement. This is a cross-section of the gastrointestinal tract. We're going to be inserting the NG tube today in the nasal cavity, having it going down the back of the throat, past the tongue, into the esophagus, the stomach. We're not going to be inserting it into the small bowel or the large bowel, but we want it to be roughly mid-epigastric when we're done. There are several contraindications for nasogastric tube placement. One of them is severe facial trauma, and the reason for that is not only do you have injury to the nasal cavity itself with the bleeding and everything, that you have a possible basal skull fracture. If that basal skull is fractured and you insert an NG tube into that nasal cavity, you can accidentally insert the NG tube into the brain. Esophageal varices related to cirrhosis of the liver can also cause bleeding if you insert a nasogastric tube down into there. That is a contraindicated. If you have a esophageal bleed that you're suspecting is the varices for, then you need to be inserting a Blakemore tube instead of an NG tube to compress those varices to hopefully stop those bleeds. Now, any patient that has had gastric surgery of any type, such as a gastric sleeve for weight loss, gastric bypass for weight loss, a partial or complete gastrectomy for any reason, a Roux-en-Y surgery for pancreatic cancer, these are all deform the stomach, make the stomach into a smaller pouch. These are contraindicated for nasogastric placement blindly. They have to have the nasogastric tube placed with the endoscope because you can easily rupture the stomach. We can have potential complications of NG tube placement at any time. The number one complication is bleeding because the nasal cavity is a very vascular place. The esophagus is a very vascular place, and if you're too rough, you can cause bleeding. Accidental placement into the lungs can happen, and you can have aspiration of stomach contents. Another problem is accidental placement in the brain, as seen in facial trauma with basal skull fractures. Rupture of the stomach or the esophagus can also happen because you may not be able to see everything that's going on that patient on the inside. So you want to take care when you place a nasogastric tube. There are many reasons for patients to have nasogastric tubes placed. Some of them is decompression of the stomach for patients that have either intestinal surgery or they have a bowel obstruction to help with keeping the stomach free of fluid and whatnot so the patient isn't vomiting, to allow for bowel rest, temporary feedings if the patient is unable to swallow, administration of medications that the patient may not be able to tolerate drinking by mouth, such as acetylcysteine for patients who have had Tylenol overdose poisonings, evaluation of gastric bleeding when it's suspected it is coming from the stomach and not from the esophagus. We're now going to discuss nasogastric tube insertion. Number one thing is to explain the procedure to the patient. Just don't try to explain to it while you're in the moment. Just sit down and explain to him, this is what's going on, this is how it's going to feel. Yes, it's going to be uncomfortable. I'm going to help you get through this procedure. We're going to talk about it. We're going to talk you through it. I want you to try to follow directions. It's always very important. It really does help the patient do well with the procedure. You're going to gather your supplies. You may want to get a chucks in case the patient is vomiting so they don't get stomach contents all over you, gloves, nasogastric tube, lubrication, catheter tip syringe, tape or a securement device, pH testing, a stethoscope, anti-reflex valve, especially if this patient is going to be on suction to decompress that stomach. You might also want to consider other things. Some people prefer to have a patient use a cup of water in a straw to swallow while they're inserting the tube. I don't use it myself personally. Another thing you might want to hand the patient is an emesis bag. We're going to then assess the nasal patency. You want to place the nasogastric tube in the side of the nose that has the clear sounding inhalation and exhalation that feels clear to the patient, especially if the patient has had a history of a nasal trauma, like they fractured their nose in the past or have had nasal surgery. Those nasal passages might be smaller than normal. You might need to go down a tube size if that's the case. To assess this, you're going to occlude one nair, and you're going to have the patient sniff in hard. And then you're going to repeat it for the other side, and you're going to ask them which side feels clear to them. You're going to listen to see which sounds clearer to you. And you're going to place that tube on the clearest sounding side. You're going to then measure your NG tube for depth. You're going to start with the tip of the patient's nose. You're going to go to the earlobe and down to the xiphoid process. This measurement is accurate for all age groups from infant to adult. Now this is where we're going to begin the steps of insertion. We're going to place the patient in an upright position. You want them in a sitting position. You're going to don your gloves. I like to warm the end of the NG tube by placing the end in the palm of my hand and wrapping the tube around my hand at least once or twice and hold on to it while I finish setting up everything, getting the lubrication out and everything, making sure my tape is torn and ready to go. This helps warms the tube up and in my opinion makes it a little bit more comfortable and easier for insertion. You're going to lube up that tube with that water-soluble jelly. You're going to gently insert the tube into the nares. You're going to follow the base of the nasal cavity because you do not want to angle it upward to the top of the nasal cavity where the vascular system is, and you don't want to scrape along the nasal septum. You want to avoid angling it upwards. You want to insert it straight back until you meet some resistance. Once you hit that resistance, that means you hit the back of the nasal passage. Now the next technique is where it takes a little bit of practice. You're going to start twisting that nasal gastric tube and push in at the same time. While you're twisting, that's going to flip that tip of that nasal gastric tube around the back of the nasal passage into the oral pharynx area. When you tell the patient when they feel the tube in the back of their throat, you're going to have the patient tuck their chin hard to their chest. You're going to instruct the patient to swallow while inserting the tube forward. You're going to say, swallow, and you're going to push the tube in. Swallow, and you're going to push the tube in. Swallow, push the tube in. You're going to continue doing that until you meet your tube measurement placement. As seen in this patient, this patient is using a cup with water and straw to try to facilitate that tube going down. Keep in mind, if the patient is drinking the water and they can start to gag and have a gag reflex, and they can start coughing and spitting and having a little bit of difficulty breathing. If that happens, have that patient stop drinking, stop pushing the tube in, just give them a minute, talk them through it, have them breathe in through their nose and out through their mouth. Once the tube is placed, you're going to secure the tube to the nose. You're going to have the patient hum or talk to make sure the tube is not in their vocal cords. You're going to have the patient open the back of their mouth to check to make sure the tube is not coiled in the back of the mouth. You're going to place the tube over the epigastrium, and you're going to take your catheter tip syringe, put it on the end of the NG tube with it full of air, and you're going to inject air into the tube and listen for gurgling over the epigastrium. Once you hear that, you're going to pull back on that catheter and the syringe catheter tube, and you're going to see if there's stomach contents coming up. If you get gastric contents. You're going to test it for your pH. Then you're going to place your anti-reflex valve on the vent part of the tube, which is usually a blue portion of the tube, and if the order is to hook it up to suction, you're going to hook it up to low intermittent suction. You're going to always want to document which nair was used, document the NG tube size, how many attempts it took, document the depth of the insertion at the nairs, document checking of placement, document any complications such as bleeding, document gastric output and pH testing. If the patient was placed on suction, you're going to document the settings of suction. Keep in mind, for gastric tubes, nasogastric tubes, you're going to want them on low intermittent suction to prevent trauma to the stomach lining. Some pearls of wisdom. Always keep in mind that you need the right size of tube for the job. If you have a patient that you're sucking out blood out of their stomach, you're going to be sucking out blood clots, you want to use a large French NG tube to do that. You don't want to put an 8 French in because it's going to get clotted off and you're going to have to replace it. Likewise for feedings and everything, you just want to make sure you use the appropriate tube for the job at hand. Now, if you have a patient that is very sensitive and does not tolerate the tube going into the nose, you can ask the doctor for a viscous lidocaine. A good trick of mine is I like to take about 5 cc's of viscous lidocaine. I have the patient tip their head back and I instill that viscous lidocaine 1 milliliter at a time as they sniff a bit, and just at first, and then after I get 2 or 3 milliliters in, I just instill the other 2 milliliters into the nose and have them with their head sit back just tipped up to numb the area and to help lubricate. You always avoid scraping the tube along the nasal passages as much as possible to prevent bleeding. Warm the tube and shape it in your hand. That will really help with getting that tube down into that airway, not the airway, but into the esophagus. Always use an anti-reflex valve on NG tubes, especially if you're using suction. Make sure there's no tension on the NG tube once it's secured to prevent nasal ulcers. In conclusion, you always have to check for contraindications to NG tube placement. You do not want to do something untoward to that patient. Always explain the procedure to the patient. Gather your equipment. Make sure you have everything ready to go before you start. Always place that patient in a sitting position if the patient is conscious. It may change if the patient is intubated because there's only one place to go down. Viscous lidocaine can make the procedure more tolerable. Check placement before instilling anything into the NG tube. Always document. I can't say this enough. Always document the tube depth before you instill anything. Always document that you check for placement before you instill anything. Just always document what you're doing, because if it's not documented, it's not done. And then following this PowerPoint, we do have a video where I'm going to be inserting a nasogastric tube on myself. So please watch this for nasogastric tube placement. I hope you guys enjoy that. And thank you for your time.